Okay, so who have seen a sick patient before? Just write one if you have seen a sick patient before in the hospital or outside the hospital. Okay. I guess these days that you guys are not able to see sick patients because of the lack of clinical exposure because of the COVID pandemic, but that's okay. And who have participated in a code before, which is basically a code blue or a cardiac arrest management, usually in the hospital, or at least you have observed it before. Nobody have seen it or participated in a code before? Okay, interesting. So just to go through the objective, we're going to talk about prevention, recognition, and management of critical ill patients in cardiac arrest and the resuscitation team dynamics. This is something that you're going to understand and know once you start seeing or participating in managing sick patients or critically ill patients or codes that happens in the hospital. So prevention is that you need to act before it happens. You should not wait until the patient crashes or until the patients go into cardiac arrest. For example, if you see these monitors, what do you see abnormal in that monitor? So what are the abnormalities in this monitor? Heart rate, okay, the heart rate is a bit fast. What else? Oxygen is 92%, which is borderline. BP, yes, BP is 84/43, which is on the lowish side. So is that patient critically ill or not critically ill? Or is he sick or not sick? Okay, he's probably sick, yes. Is he stable or unstable? Okay, so what will happen if, okay, so he's unstable, he's sick, he's critically ill. So what will happen if you do not do anything and you keep him like that? These numbers most likely will deteriorate. The blood pressure will continue dropping. The heart rate will increase until it becomes bradycardic and stops, and the saturation probably will drop. So if you see these numbers, you have to intervene as soon as possible and give the intervention or give the treatment the patient needs before he crashes or before the patient goes into a profound cardiac arrest. And that is the idea of prevention, and that we should act before it happens, before bad things happen to that patient. So immediately act fast. Do not wait. If you know what's the problem, then fix the problem. If you're not sure, call for help to come for people to come and help you managing that patient. Again, chain of survival. It has education, monitoring, recognition, call for help, and response. This is also as part of the chain of survival. You need to educate people to be able to understand and to know the ways of managing those patients. You better recognize those patients immediately. You guys knew that this patient has abnormal vital signs. You guys understood that he's unstable, and you guys thought that he was already sick and that you needed to intervene for that sick patient. So check for responsiveness as part of the checking for any victim. So make sure that he's responsive. If he's not breathing or only gasping, make sure that you know that. And you have to check the pulse within 10 seconds. And you have to make sure it's definite pulse, not pulse that you're not sure if it's there or not. And all these things can be checked within 10 seconds. So again, early recognition, early CPR, early defibrillation, early advanced care. Things needs to be done as soon as possible. Early, 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 and early. So early intervention, early recognition is very important. This is the system-specific chains of survival that usually IHCA stands for in-hospital cardiac arrest and out-of-hospital cardiac arrest. Code blue is basically when you have a patient who collapse and the nursing team or the ward team call for code blue to come to help him. And this is the code blue team that will come to see what's going on into the intervention. So these are the cases that you're going to see that when you're working in the hospital and you're going to be participating in for those patients. So the main thing is that you need to know what to do. And the first procedure is to check your own pulse. You have to focus, you have to know what you're doing, and you have to know how to approach that patient. If you look at the learning pyramid, which is basically how people learn their skills or their knowledge, usually the lecture will not give you much information in terms of your practice. Reading about the topic will give you 10%. Audio visual showing you a presentation and visuals are probably going to give you 20%. Demonstration and showing you live how to do the interventions is going to give you 30%. Discussions, asking questions, answering questions, clarifying things will give you 50% knowledge. Practice doing is that when you're practicing and doing things by yourself and being supervised, then this is basically going to give you 75% of the learning experience. And lastly, when you teach others, then you already got 90% of your knowledge that you're giving to other people. So we usually try to optimize it up to 90% when you teach others, but practicing would be the best ideal method of learning process. Get training. So you need to get training to be able to help your patients. If you don't get trained, then you're not going to be able to help them because you don't know how to do it. One of the main training courses is the ACLS from the courses from the American Heart Association, which is available for anyone, including students. Again, we've been through the CPR, the CAB, circulation or compression, airway, and breathing. You have to push hard and push fast, but not too fast and not too hard. What's your try to reach your goal of 100 to 120 compressions per minute and 5 to 6 centimeters deep in terms of pushing the compressions. High quality CPR is key. Allow complete chest recoil after each compression. If you push and you don't allow the recoil, then the circulation will not be that good if you don't allow full recoil of the chest. Minimize interruptions. Do not stop CPR or compression unless you have to. If you want to check for pulse, if you want to give a shot, then you would stop and check for that. Compression's ventilation ratio is 30 to 2 and rotate every 2 minutes. So why do you have to rotate every 2 minutes? Why just one person, not just one person, do all the CPR for the next hour? Do all the compressions? Why do we have to switch? Anybody knows? It takes effort, okay. Yes, it's the same as it was like you're doing an exercise or going to the gym or doing something physically. It's a physical exercise, and if you do it for beta up to block, so he's gonna get tired, he will get fatigued, and then his compressions will be very bad after 3 or 4 minutes. So that's why you have to switch, because people, they will get tired. This is the CPR algorithm that we have checked. You're gonna have to check the rhythm of VTAC or VFib. You're gonna shock him. Of course, not a regular VTAC. It's gonna be a pulseless VTAC. Continue CPR, monitor CPR quality. The drug therapies that you're gonna give during cardiac arrest is either epinephrine, which is basically given every 3 to 5 minutes, amiodarone for refractory ventricular fibrillation or pulseless VTAC. Consider advanced airway for such patients, and treat reversible causes. Because the CPR itself is just buying you time until you fix the reversible causes. If the patient is hypoglycemic, until you give him the treatment or give him the glucose to increase his glucose level, you're just going to do CPR until you fix the problem. Here, this is the algorithm for the advanced life support. You're going to check the rhythm. If it's shockable, then you're going to go with VFib and pulseless VTAC. You're going to shock, get the IV or IO. IO is intraosseous. If it's shockable, shock him again. And CPR every 2 minutes. Epinephrine will be given every 3 to 5 minutes. And again, if it's shockable, you're going to shock him again. You give amiodarone or lidocaine as the second medication to give, and treat reversible causes. If it's non-shockable rhythm, which is basically asystole and pulseless electrical activity, you're going to give only epinephrine as the drug of choice, and you're going to check if the rhythm is shockable. If it's shockable, you're going to go back to 5 and 6 to the shockable algorithm. We're going to talk about the PEA. PEA is basically pulseless electrical activity. There is some electrical activity, but the patient has no pulse. Okay. So the H's and T's, these are the H's and T's that will help you think about the possible causes or underlying causes of the cardiac arrest. If you go by the H, hyperkalemia, hypoxia, hypothermia, hydrogen ion excess, which is acidosis, hypovolemia, hypoglycemia. T's, tamponade, cardiac tamponade, tension pneumothorax, thrombosis, either pulmonary embolism or thrombosis, myocardial infarction, toxins, trauma. So these are the most common causes, almost of 90% of cardiac arrest, that you have to think about while you're doing CPR. So these causes, you need to memorize them and know them whenever you're seeing a sick patient or a cardiac arrest patient. This is an easy way to remember them. Hypoxia is in the lung. This is the letter H. Hyperkalemia in the kidneys. Hypovolemia in the abdomen or the spleen. Hypothermia is in the temperature with the mouth. Tamponade is in the heart, which is the T, letter T. Hypertension, pneumothorax, and thrombosis within the heart and the lungs. The pulmonary embolism and myocardial infarction. Toxins are the toxin that goes into the stomach. This is an easy way of remembering or recalling them. So code blue, you are the students and working on your notes, and code blue is called for the patients on ward 23. You run down the hall and you are the first one to arrive to the scene. What would you do? So you're the first one to arrive after a code blue. What are the first things you're gonna do when you arrive? Okay, you can answer on the group chat. ABC, okay, good. This works for everything mostly. So ABC, you're gonna check for the airway, you're gonna check for breathing, you're gonna check for circulation. I mean, what you can do before checking the airway or checking the ABC is just make sure that the patient or the victim is actually in a cardiac arrest or unconscious. How would you check for that? How would you check for his level of consciousness? If someone thinks stable or not, yes. Okay, this is part of the ABC. You're gonna assess the ABC. And based on the ABC, you're gonna know if he's stable or not. Okay, what you can do is just to check and ask him, are you okay? What happened? And if he's not responding after 5 seconds, then you start the ABC, which is basically gonna have to go through the airway and breathing and circulation. So you check the ABC, you check the airway, you check the pulse, you feel a thready carotid pulse, the patient feels tachycardic, blood pressure cuff is not reading, so he's hypotensive. Patient is agonal breathing, not responding to verbal or painful stimuli. So you try to wake him up, he's not responding. And the nurse looks at you and says, Doc, what should we do? So what should we do now? So as I said, he has thready pulse, agonal breathing, blood pressure cuff is not reading, he's hypotensive. What will we do? Okay, nobody's answering. You guys can try. Okay, compressions, oxygen. Okay, so some people, they would start compressions because they said, okay, agonal breathing, I'm not sure if he has a pulse or not. Okay, good. Oxygen, you can start him on oxygen. So starting CPR. Okay, good, good. Okay, excellent. So at arrival, you do a quick initial assessment, which is the ABC, as you guys said, and assess his responsiveness and vital signs, and immediately someone's begin compressions. So compressions has been started, probably oxygen 100% has been started, and oxygen is applied to the patient by the nurse. So excellent. Those are the main interventions that you're gonna have to do for such patient. You will also want to start an IV access, either by the nurse or by you, or an intraosseous. Intraosseous is the same as the IV access in terms of medication that you can give. And then you're gonna check for the EKG or the rhythm on the monitor. So what are these for rhythm and cardiac arrest? So let's start with the first rhythm here. What is this rhythm here? Okay, so you can write the rhythm on the VF, okay? VF, so this is ventricular fibrillation. Chaotic waves all around. Is this shockable or non-shockable VF? Will it respond to shock or no? So VF, is it shockable or non-shockable? Will it respond to an electrical shock if you give it or not? Yes, it will. Okay, excellent. What about the next rhythm here? Right above, right to the right, right to and above. Okay, so what is this rhythm here? You guys can try it, that's fine. VTAC, okay, VT, okay, so it is VTAC, and we're talking about pulseless VTAC here. So it's a regular wide complex pattern زي شو اسمه الجبال. Okay, So it's always higher, it's wide. This is pulseless VTAC. So what about VTAC? Is it shockable or non-shockable? Will it respond to shock? Yes, okay, so it's shockable, excellent. What about this rhythm here? What is this rhythm? So we're talking about this rhythm here. Okay, asystole. To the left is asystole, correct. What about this rhythm here? In a patient who's in cardiac arrest. So you check the pulse, and there is no pulse, and this is the rhythm that you see on the monitor. What do we call that? No, it's not bradycardia. It's normal sinus rhythm, but I'm talking about a patient with no pulse. Patient with no pulse, and you see this rhythm on the monitor. It's pulseless. It starts with pulseless. Again, he's pulseless. He has no pulse, then the term is changed. This is something called, yeah, no pulse, and he's unconscious. So this is called pulseless electrical activity. There is some electrical activity, probably normal or bradycardia, but because he's pulseless, this is called pulseless electrical activity, or PEA, okay? We have mentioned that, I think, before as part of the algorithm. If we go back, asystole and PEA. PEA stands for pulseless electrical activity, okay? Even if it looks normal, if there is no pulse, it's called pulseless electrical activity. So you see all the names, okay? This is pulseless VTAC here, and here it's VF, here it's asystole state line, and here it's pulseless electrical activity. This is only the rhythms that they're gonna find, and any cardiac arrest, it's only gonna be 4 rhythms, either called pulseless electrical activity, VF, pulseless VTAC, or asystole. And we've discussed that here. This is part of the shockable, non-shockable, asystole, PA, PF, and PV. Okay, next is the team roles in a cardiac arrest. The code leader will be standing at the feet of the patient because he wants to see everything. The RT or the respiratory therapist will be dealing with the airway. There's a nurse, there is a physician, there is a nurse who records the document situation. One nurse will do the IV access, delivers the medication. One physician will do the pulse check, do the compressions, assist with the IV. There is the compressor here. There is the other nurse to attach the monitor. And the team leader or the code leader, he will lead the process completely by himself. If he needs any help, he's going to call for help. Okay? So everybody has a role, a specific role during a cardiac arrest. Communication is important in cardiac arrest or any code procedure. There is something called closed loop communication. Do you know what is closed loop communication means? What does it mean? Anybody has any idea about closed loop communication? So So you can write your answer on the chat group. What do we mean by closed loop communication? Okay, so to explain it is that closing the loop is that when someone or the team leader says, please give 10 milligrams or 1 milligram of epinephrine to the patient. I'm giving an order, and then the nurse gives the 1 milligram of epinephrine to the patient, and she replies back to me saying, 1 milligram of epinephrine was given. And I just say thank you. So I know that she told me, she replied back to me that the 1 milligram of epinephrine that I asked her to give was given. So I know that she gave it or not. Because what happens sometimes is that the physician gives an order and the order gets carried out and nobody tells the physician that the order was given or not. Okay? And this helps to avoid any confusion or misunderstanding and to clarify things. Okay? So the team leader gives a clear assignment to the team member. The team members responds with voice and eye contact and says, okay. And the team leader listens for confirmation, and the team member reports when the task is complete. Okay? So for example, if the team member said, oh, I didn't hear, did you say 1 milligram or 2 milligrams? And then the team leader or the person who's giving the order will say, no, I said 1 milligram. And then 1 milligram will be given, and then 1 milligram of epinephrine will be confirmed that the 1 milligram of epinephrine was given to that patient. So that will make it easier for communication and avoid any confusion or misunderstanding between the dynamics of the team members. And that's why there is a clear role. So you don't want people to do certain things. If the airway assistant is his job, that his job is airway, then you would not give him a task other than dealing with the airway. Know your limitation when you're doing your resuscitation. If you're a student and someone asks you to give or to do an IV access and you don't know how to do an IV access, you have to know to tell the team that, sorry, I'm not trained to do an IV access. I need help, or I cannot do it on my own. So very important not to be a hero and know your limitation. Knowledge sharing. Okay, if you see that something is wrong or something is being done wrongly, then you report that. Okay, you can say, oh, we just gave the 1 milligram of epinephrine just 1 second ago, to share the information or to share the knowledge. Constructive intervention. If someone you see that he's doing the IV access in the wrong position, then you come and instruct him in a constructive manner. Let me show you how to do it. No, it's better to do it this way. Instead of saying, no, you don't know how to do it, just go away. This is more constructive intervention for the team members to be cooperative and work as a team. Summarize and reevaluate. If you're having a patient with MI and cardiac arrest, you're going to have to verbalize to say, okay, we have a 20 years or 40 years old male with MI, ST elevation MI, who's in cardiac arrest, and you're going to summarize what you're doing. You're going to give him epinephrine. We're going to shock him if it's indicated, and we're going to continue that for the next 15 minutes. So everybody, all the team members, they will understand your thought process and what you are thinking about. Communication errors, it happens, and that's why you have to clarify orders and clarify things to make sure that you don't go into communication errors. So this is an example of communication errors.
We're out here now, man. I hope you're happy. Yeah, I'm happy. Well, good. Now what? Well, I just think we should have our safety vest. Oh, come on, man. Those vests are for daggone people who really like to use them. Dude, I don't even see them. They're colorblind, stupid. Golly. Oh. Hey, Toddy, did you get something? Toddy, what'd you get? Toddy. Toddy, oh, my God.
911, what is your emergency, please?
Yes, please help us. I think my buddy, I think he's dead. What do I do?
Sir, calm down. I can help you. We'll walk through this together. First, I need you to make sure he's dead.
Well, I can do that. Hold on a second.
Okay. So this is basically the confusion or misunderstanding that happens during critical situation that applies to cardiac arrest or whatever. If the order or the thing that gets delivered to you that doesn't make sense to you, or you think that there's something wrong, you have to clarify and ask, are you sure? Do you really want that? Did you mean this or that? Sorry, I couldn't understand. What do you mean by giving this or giving that? What did you say about the dose? Are you sure you want me to give 10 milligrams of epinephrine? So these things will clarify the team dynamics and the communication between the team members. So again, closing the loop is very important to clarify the communications and make it more streamlined. And to summarize, prevention is critical. So you don't want to wait until the patient gets sicker. Recognize and don't miss anything in terms of critical signs and signs of critical illness. Use the BLS and ACLS algorithm for your patients. Think about the reversible causes, the HNTs, when you're dealing with a sick patient or a cardiac arrest patient. And do your life support training to be able to help out in a cardiac arrest situation. And that's it for today. Any questions you guys have? If you have any questions, please write it down, or you can raise your hands or talk on the mic. Are you guys able to raise your hands? Do you have this option or no? Because I don't see that option here. Okay, عادل الشمري. عادل, can you speak?
السلام عليكم.
السلام ورحمة الله وبركاته. في أحد عنده سؤال؟ So you can write your question in the comment section in the group chat, or you can speak using your mic.